Raise your right hand, please, doctor.
Yes, sir.
Do you swear or affirm to tell the truth, the whole truth, and nothing but the truth, so help you God?
I do.
You may have a seat right there.
Thank you.
Okay, Mr. Selden.
Thank you. Good afternoon, Dr. Banerjee.
Good afternoon. Can everybody hear me? Thank you.
Yes. Tell us your name and how you spell it.
My name is Dr. Priya, Priya, and last name is Banerjee, Banerjee.
Where do you currently work and what's your title?
Sure. So, excuse me, I'm self-employed at my company named Anchor Forensic Pathology, and I'm based in Barrington, Rhode Island, just outside of Providence.
Have you authored any publications or anything related to it?
Yes, I don't think I fully answered your last question. So I'm a forensic pathologist, and so I've worked in that field going on over 14 years. And so during my training, well, I mean, I'm talking about I was an attending, and then there was training prior to that. So all in all, there were many occasions that I've done research myself and then published those articles, or then became a senior author, helped other individuals perform the projects, and we together presented them and published them.
And that's in your chosen field of forensic pathology, is that correct?
So I have publications throughout. I have cancer research articles. I have some basic pathology articles, as well as many publications in forensic pathology as well.
Okay. Do you have any teaching experience?
Yes, quite a bit. So in Rhode Island, let's see, I used to teach at the Roger Williams University, where I designed and taught a year-long forensic pathology and crime scene investigation course that was 2 semesters. I did that for quite a while, and then I subsequently left that job due to personal reasons. I also taught at the Boston University Medical School, their graduate program in forensic sciences. Again, it was crime scene investigation and forensic pathology, and currently still hold, since I think 2011 or 2012, a clinical assistant professorship at the Brown University Laboratory Medicine and Pathology program.
As a forensic pathologist, do you conduct autopsies and issue reports from that?
Yes, that's one of the many roles I do as a forensic pathologist. That's really what I'm trained to do, and as you've heard previously, that's one of the main tools we use as a forensic pathologist to make diagnoses.
What? Can you approximate at all how many autopsies you've done in the past?
That's a gross approximation, and I would say probably close to 3,000 now. So autopsy, my training stems back to my days at residency at the Johns Hopkins Hospital, where we learned and performed autopsies. I then went on to do a fellowship in forensic pathology, where I was, day in and day out performing autopsies. And then I was an assistant medical examiner for the state of Rhode Island for over 11 years. So again, very diligently doing autopsies. So all of those together, plus I've done some service work in various other offices that needed help, such as New Hampshire, Maine, Las Vegas. I've done that. And so this is just, I don't keep tallies, but I would say approximately, let's say 2,900 to 3,000.
Fair enough. Are you board certified in any of these areas that you're talking about?
Yes, so after I completed my residency at the Johns Hopkins Hospital, I sat for my pathology boards, which was in the field of anatomic pathology. So that's like being in a hospital, looking at slides, whatnot. Autopsy is a part of that. So I was generally boarded in anatomic pathology. And then after I did my fellowship training, I was then eligible and on the first attempt passed my forensic pathology boards.
Do you have any medical licenses anywhere?
I currently hold 2 active licenses, one in the state of Rhode Island and one in Nevada. I also have a inactive, good standing licensure in Pennsylvania.
At this time, I would like Dr. Banerjee certified as an expert in the field of forensic pathology.
Does the state wish to engage in voir dire?
Your Honor, the state accepts the witness's credentials.
All right, the court declares Dr. Banerjee to be an expert in the field of forensic pathology and anatomic pathology.
Thank you.
Permission to approach the clerk, Your Honor?
Yes.
And Your Honor, I am asking that this particular exhibit be marked as defense exhibit, whatever the next number is.
It's defense exhibit number 12.
Thank you.
Permission to approach the witness, Your Honor?
Yes, you may.
Dr. Banerjee, I am handing you what's been marked as defense exhibit number 12. I'm going to ask you to refer to this document. I'm going to go back and ask you some questions, okay?
Sounds good. Thank you.
Could you identify this document, what it is?
So this is my 7-page report that I submitted to you that summarizes or contains all my conclusions related to this case.
Okay. You're starting to fade away a little bit.
Oh,
Please
sorry.
talk in the microphone. Thank you.
I'm very rarely accused of that.
On page 2 of that report, you specify what records you've received in preparation of that report. Would you please go through the records you've received?
Yes, so I've itemized in my report in no particular order. All of them were submitted digitally. So just the first autopsy report for Michael Brandon Cochran, West Virginia, number 2019-3671. That is the first autopsy that Dr. Kubitschek performed. I also have medical records, 2 sets, one from Raleigh General and the other from Charleston Medical Center. I have an array of scene photographs of the candidate scene, including multiple pictures of a Humalog insulin Lispro vial. I have Dr. Uribe's second autopsy report and Dr. Diane Krieger's expert report.
Now, you listened in to expert reports or expert testimony in this case, but that was subsequent to you authoring this report. Is that correct?
Correct. Yes, I was allowed to by the judge with permission to also listen to Drs. Uribe and Krieger testify, but my opinion as written here is all formulated based on their written reports as well, and the summation of all this.
Okay. I'd like to skip down to the bottom of page 2.
Okay.
you have a heading marked discussion. Do you see that?
Yes.
Okay. I'd like to skip over paragraph 1 for now and go to paragraph 2. In that paragraph, you state that Mr. Cochran first underwent an autopsy by Dr. Kubitschek on September the 4th, 2019, which was 7 months after his death. Is that correct?
Yes, approximately 7 months.
Okay. Your Honor, I have another exhibit that I'm going to be questioning this witness about. Permission to approach the clerk.
Very well.
Defendant's exhibit number 13, Your Honor.
Thank you.
Now, I'd like to warn the jury ahead of time. These are photographs, and they're somewhat gruesome. Dr. Banerjee, can you identify this exhibit?
Yes, so this is a hard copy printout of an array with 4 autopsy pictures with the same case number that I referenced, 19-3671, with Dr. Kubitschek's initials also on the placard in the photos. So these are at least 4 of the many autopsy photos that were submitted to me.
At this time, I'd like to move for admission of Dr. Banerjee's report and this exhibit.
Any objections, Mr. Truman?
No objection, Your Honor. Thank you.
All right. Defense exhibits 12 and 13 will be admitted into evidence.
Now, you've already identified this photograph. I want to go back to your description under decomposition, page 3, paragraph 2.
Okay, let me just flip there. Yes.
Does this photograph accurately convey the advanced state of decomposition as photographed by Dr. Kubitschek in his autopsy?
Yes, so this, unfortunately, embalming and burial does not keep the body in the same state as when one passes away. So even though the procedure is supposed to, it's still not perfect. And so you can see that 7 months later, Mr. Cochran's body was in a moderately decomposed state with moderate insect activity present, and those are words extracted from Dr. Kubitschek's autopsy. That's how he described it.
I'm going to remove the photograph.
All right.
On that same page, what was the description and the condition of Michael Cochran's heart on autopsy?
Yes, so the heart weighed 450 grams, and it wasn't described clearly as such, but assuming it was also moderately decomposed like the rest of him, it was, it follows that weight, as you've heard earlier, tissues and organs, as they fall apart with decomposition, they get lighter in weight. And so taking that into account, this is a relatively enlarged heart for someone his size and his stature.
Why is that significant, the enlarged heart?
So the heart is ironically one of those muscles that you don't really want to enlarge unless you're an Olympic athlete or very well conditioned. It often enlarges secondary to what we say stress. Now, stress can be anything like high blood pressure, anything that's sort of a continued stress on the body. It's not one episode. It's going to be longer term effects. So sometimes chronic substance abuse, exercise can help, but when we say it's a pathologically enlarged, abnormally enlarged, that's not a healthy heart.
You have a discussion about pseudoephedrine use.
Yes.
Please explain that.
Sure. So within the clinical records I was given, certain substances that are considered controlled substances, which pseudoephedrine is one, is monitored, and the prescription sort of history is monitored. So that's how I knew he was on it. And pseudoephedrine is Sudafed, and we know that one of its side effects it's a stimulant, meaning that it will raise your blood pressure.
What about your statement about reported history of pseudoephedrine and stimulant use and the use of enclophamine use? How could these factors have affected Mr. Cochran?
Sure. So I assume that enclomiphene, wasn't a prescribed medicine. It was what the records say was illicitly obtained over the internet, and non-prescribed, I should say. And so all of these factors, when your heart is enlarged, it is a risk for sudden death, which is what we call an arrhythmia. The heart has an electrical system that helps us beat. Even as we sit here, we don't have to think about it. And when the heart gets thickened, abnormally so, the electrical system can basically short circuit, and then you miss a beat, you don't have a heart rate, you don't have a blood pressure, and you die. There really isn't any fingerprint of an arrhythmia. That's an electrical signal, right? So when you're alive, there are cardiologists that specialize in that, and they can, like an EKG is the electrical tracing of the heart. But once you are deceased, there's no way to really, there's no traceable rhythm. And so structurally, when we see an enlarged heart, we're worried about an arrhythmia as a possible cause of sudden death.
Could these factors in your discussion about a fatal arrhythmia or heart attack, could this have been a possible factor in Michael Cochran's death?
Yes, I just say arrhythmia, heart attack, I sort of classify differently, which I won't get into, but the abnormal rhythm would be an arrhythmia, and if it's a fatal, there's different tracings, which I'm not going to get into, but fatal arrhythmia can occur, and obviously with a decomposed heart, just like the rest of his body, that really limits making the diagnosis under the microscope. We can, again, just say that the heart was enlarged based on its weight.
So from that explanation, a fatal arrhythmia would not show up in autopsy, correct?
Correct. We have a structurally abnormal heart, which we know is at risk, but a fatal arrhythmia leaves no identifiable sign at autopsy, especially in a decomposed specimen.
What findings were made regarding the possibility of pancreatic tumors in Michael Cochran's body?
I know there's been some discussion about this, but upon review of the first autopsy report, again, the pancreas is one of the first organs to decompose in the body. It's full of enzymes, and as soon as we die, they start leaking, and that's what causes the pancreas to basically disintegrate. And so I think it's difficult, and I think it's improper to say that a pancreatic tumor was excluded, because 7 months later, the pancreas isn't going to be very recognizable. Even if it is, it's not going to be intact anymore to really see any types of tumors. These tumors, such as an insulinoma, can be less than 1 centimeter big. It can be millimeters, but it can still have a functional effect, which I find fascinating. But again, that's not going to be identifiable on a decomposed pancreas or organ.
Okay, and I may have missed it in your explanation. I just want to clarify. Can pancreatic tumors cause hypoglycemia?
Oh, yes, sorry if I wasn't clear on that. Yes, so that's in one of the causes, potential causes of hypoglycemia, is a pancreatic tumor if it creates insulin. So tumors don't act like normal organs. And so if it's a tumor of the cells that make insulin in the body, and there's an sort of bad acting collection of them, then they form this tumor, and then they can pump out insulin that could cause low blood sugar hypoglycemia. There was no such, I think the capabilities of identifying such is very limited in a decomposed body.
Dr. Uribe stated that pancreatic tumors on autopsy were excluded in the first autopsy. Is that a correct statement?
I think not identified versus excluded are two different issues here. Not identified is true because the pancreas and other organs, again, are decomposed. Excluded is inaccurate because, again, that decomposition means it's 7 months later and it could have been there. We just can't see it based on the condition of the organ and the body in general.
I'd like to call your attention to the paragraph that's numbered number 3 on that page. Okay?
Yes.
You discuss post-mortem, meaning after death, toxicology tests performed. What's toxicology?
So toxicology is the basic testing of blood and other body fluids or tissues to see to try to detect, identify, and quantify any medications or substances that's in someone's body at the time of death.
Would you please discuss what tests were done or weren't done in connection with Michael Cochran's body? And along those lines.
So again, this is 7 months later.
I have a specific question.
Oh, I'm sorry. I thought
That's
you
all right.
wanted me to answer.
There's a discussion that there was no testing prior to Michael's death of, first of all, insulin. What's the significance of that?
So when he was alive then, you're
Yes.
saying? Okay. Because we talked about postmortem testing too.
No,
So
I'm talking about prior to Michael Cochran's death.
Sure. So my review of the hospital record showed that there was, although low blood sugars were noted, there was no associated laboratory testing related to insulin, C-peptide, proinsulin levels, or any other medications like oral anti-glycemic agents, which are what you take to lower blood sugars, done in the hospital.
So those various tests that you're talking about, tests for insulin, tests for C-peptides, anabolic steroids, those all could have been done prior to Michael Cochran's death, correct?
Yes.
But they weren't done, right?
Per the medical records, they were not done.
and according to hospital records, etc., one of the reasons those tests weren't done was because when Michael Cochran was admitted to the hospital or hospitals, there was no suspicion of insulin being introduced into his body. And I'm talking about what they call exogenous insulin, insulin that's not produced by the body. Would that be a correct statement?
Yes, I saw no notation or differential diagnosis listed that, oh, sorry. I did not see any notation or differential diagnosis listed within the medical records for that diagnosis, like exogenous insulin having a role in his hypoglycemia.
Okay. Is there any explanation for Mr. Cochran's urine screen, which was positive for benzodiazepines?
So this was a perplexing result to me. I think there was some confusion. Dr. Uribe said that, and there was, midazolam detected in the postmortem toxicology. Midazolam is a benzodiazepine that can be used as a sedative or anesthetic, but that was given later in the hospital, and the urine screening was done very close to his admission to the hospital. It was done at 21:05, which is 9:05 p.m. The day of February 6th. And so he had not been given, there's no records within the nursing records or the doctor's orders that he was given any such medication in this class yet. So that means in the urine drug screen, there's an unexplained benzodiazepine positivity. Now, that just means I don't know what it is. I don't know where it came from, but it's a suggestion that he's on this something, at least one, if not more, benzodiazepine medications. And that's from the urine testing.
Okay. Let's go down to paragraph 4 on that same page.
Yes.
In that paragraph, you discuss the second autopsy, which was done by Dr. Uribe 4 years after Michael Cochran's death.
Yes.
What's the significance of an autopsy being done 4 years after death?
Well, I think in this, speaking specifically with this case, unfortunately, again, the embalming is not perfect, as we saw 7 months. So although there's no photographs, there was a description written by Dr. Uribe that the body was nearly skeletonized. There was some residual tissue, but mainly bones. And so obviously that decomposition has continued. Mr. Cochran's body was, buried again and then had to be re-exhumed. So again, his body's undergoing decomposition to almost no tissues remaining. And the ones that he had described that were there with the body were all very disintegrated in a medical bag, in a plastic bag. So you can't really make any further conclusions from them. They're not intact anymore to make anything meaningful.
Because of the advanced state of decomposition, which has continued, does it make it harder to reach a conclusion in an autopsy?
So we have 2 autopsies here with 2 varying stages of decomposition, one obviously far more advanced than the other. But anytime we have decomposition, you really are working with not as perfect a body as it had been when he first died. So obviously, when I get asked the question, when do I need to autopsy my loved one? Usually I say within a week to really get meaningful results. And as time goes on, even with embalming, as you've seen, there's decomposition because the way our bodies, our tissues react, they're just going to start disintegrating. They're no longer they're not healthy living tissues anymore because the person's not living. And so you're automatically handicapped to make some diagnoses. It's still very worthwhile doing a decomposition or decomposed autopsy. You want to make sure there's no trauma, there's no big, you can see some diagnoses, even natural diagnoses, you can see trauma, even some toxicology can be done, but it's still a hindrance that, due to the decomposition being there. And actually, in decomposition autopsies, there's an extensive explanation that I, sort of qualify the description of the organs, as well as the toxicology lab has to be, notified that, hey, this is not an ideal specimen, this is a decomposed specimen, and sometimes you even can't send as good a specimen to do the testing because it's not available anymore.
Now, if you can answer this question, fine. If you can't, that's fine too. In general, if an autopsy is done 7 months after death, and an autopsy is done 4 years after death, would the results in the first autopsy be more easily quantified or valid, let's say, than the second autopsy?
I think that's a very broad question.
Okay.
I can speak that, again, it's still worth examining a body at any time. I really look at it when, even with decomposition present, you want to make sure there's no identifiable trauma. So even some, in skeletonized remains, I've done many of those, you look at the bones to make sure there's no fractures, tool marks, gunshot wounds, anything like that. Do the bones tell you about the patient? Sometimes you can have surgery remnants, right? You can have hardware, you can have skull fractures, whatever it may be. We x-ray them, we look at them. That can be very meaningful. You can do DNA on bone, etc. But as the organs and soft tissues decompose, more information is leaving, right? So as time goes on, less and less information is available to make, I guess, like toxicologic analyses, even looking under the microscope, even at 7 months. You can see with moderate decomposition, it's not a worthwhile exercise.
I believe that Dr. Kubicek took some tissue samples, or was it Dr. Uribe, for toxicology analysis? Do you remember?
Yes, so Dr. Kubicek did. Yes. So there was at least clotted blood and maybe some tissue samples that he sent. I don't have the report in front of me, but I know that was the analysis that resulted in the midazolam, that one therapeutic, meaning medically given, prescribed medicine in his blood detected.
But generally speaking, those slides were pretty much useless, and I believe Dr. Uribe said he couldn't make any definitive findings as to those slides. Is that correct?
Sorry, just to clarify, I was speaking about the toxicology.
Okay. I'm talking about the slides.
I see. Maybe I misspoke or misunderstood. Excuse me. When you talk about slides are where we look under the microscope. So the way it works is you have to have a light and you have to have the glass slide that has a very thin, even thinner than paper, layer of tissue on there. So that tissue means it's a section cut from the organ you want to look at. So heart, lungs, liver, kidneys, whatever it may be. And it's specially prepared in a lab, and it has at baseline usually pinks and purples to help me with my trained eye, or my colleagues like Dr. Kubicek or Dr. Uribe look under the microscope and make an interpretation. But that also, again, depends on the integrity of the tissues. So as the tissues fall apart, the detail under the microscope is no longer available. So I don't recall exactly what Dr. Kubicek's conclusions were if he took slides, but I know Dr. Uribe basically didn't submit them because no meaningful diagnosis could be made. The tissue was in such unrecognizable, decomposed state that it's not worth anybody's time, effort,
So
or money
for
to do it.
analytic purposes, those tissue slides were pretty much useless. Is that correct?
I'm not even sure he made slides. I thought he just retained them in little plastic containers in case he needed to, but I don't think he even made the slides. His comment was that it was something like no meaningful diagnoses could be made from them.
Pretty much useless, right?
Yes.
At paragraph 5 of your report, you discuss the documenting of Mr. Cochran's pseudoephedrine prescription, and then you discuss benzodiazepines, which were positive in his urine. How are these two substances related, and what's the significance of them?
Okay, so there are two medications that are controlled, meaning they have medical uses, but they're also regulated because they can be abused. So that's why each state usually has a prescription drug monitoring program. And as a part of the investigation and medical records, I received the printout for Mr. Cochran. That printout has a log that he was on pseudoephedrine for many months. However, benzodiazepine is a controlled substance, meaning like it's a medication, has plenty of medical uses, but also has potential for abuse. And there was no tracked benzodiazepine on anywhere, actually. I didn't have it in his list of medical medications at home, and I did not have it on the state prescription drug monitoring program. So I'm sorry, just to conclude
From your discussion and report, could Mr. Cochran, prior to death, have overdosed on benzodiazepines?
So, yes, that's where I was leading, that, a urine toxicology, when someone shows up at a hospital with altered mental state, meaning they're not talkative, they're confused, or they're not responding, that's why it aids doctors and clinicians that maybe we can find out what's in him because he can't tell us, and maybe that'll help us undo the effects of it, and if it'll allow him to wake up. Does that make sense? And so that is one. Overdose is a possibility. I have no idea which benzodiazepine this is. I don't know how much it is. It could be one, it could be more than one. I have no idea. I just know that was a very strange result, given that he's not prescribed this at home. And then again, it's a drug of abuse, meaning if you're not prescribed it and you're using it, that is misuse of a prescribed medicine, or unprescribed medicine for that matter. I know you can get it off the internet. I've had other cases related to benzodiazepine overdose that could be illicit, if you will. So I think that's a strong differential,
Okay.
given.
Let me interrupt you right
Okay.
here and clarify. Did you state in your report that benzodiazepine overdose is a common cause of death alone or in combination with other substances?
Yes, at least where I've practiced, benzodiazepines are often misused, abused, if you will, and if taken in excess can cause overdose, as I said, alone, or it's often used with many other substances that may or may not show up on a urine drug screen.
Okay. Did Mr. Cochran, prior to death and according to the medical records, exhibit any symptoms of benzodiazepine overdose?
I mean, any overdose, the way it affects your body, and a benzodiazepine.
I'm asking specifically, Mr. Cochran, in your review of the medical records,
Yes.
did he exhibit symptoms of benzodiazepine overdose, and what symptoms are indicative or indicate possibly
Sure.
benzodiazepine overdose.
Sure, so they're nonspecific, but respiratory arrest where he stops breathing. He can aspirate gastric contents into his lungs, like meaning vomit will come up and he'll breathe it in. Confusion, collapse, all of that is possible as the excess medication use and abuse causing overdose.
Can it cause seizures?
Not usually.
Okay.
I think, just to clarify, I think if he's in a prolonged state due to an overdose where his brain is deficient of oxygen, that could have seizure-like activity because the brain is injured. But the medication in and of itself does not cause seizures. It can sometimes be given for seizures.
Is hypoglycemia related to benzodiazepine overdose?
I think it could be. I don't know that it's directly related, but I think once the body starts getting in dysfunction and disarray, you can see hypoglycemia.
Okay. So it might have been a possible cause of Michael Cochran's hypoglycemia. Is that possible?
Benzodiazepine overdose is in the differential.
Is that a yes?
Yes, sorry.
Let's take our afternoon break right now. Members of the jury will break for 10 or 15 minutes. Please do not discuss the case among yourselves or with anyone else. You may follow the bailiff to your jury room. All right, are there any matters we need to discuss out of the presence of the jury?
Not from the state, Your Honor, thank you.
Not from defense, Your Honor.
Very well. Bring in the jury, please. Deputy Fry.
That's the one we sent out. And I'll show you where to put those two.
All right, we continue with the direct examination of Dr. Banerjee. You may proceed, Mr. Selden.
Thank you, Your Honor. Picking up where we left off, at the top of page 4, the first complete paragraph, you state that although it is not studied well, hypoglycemia is a real and life-threatening condition that may occur in benzodiazepine poisoning. And you go on to say, thus, this is a real possibility for Michael Cochran's cause of death. If I am interpreting that correctly, what you're saying is benzodiazepine may cause hypoglycemia. then the hypoglycemia may result in death. It's kind of a progression. Is that a correct interpretation?
Correct. I say that this unknown benzodiazepine at unknown levels, there's reports of benzodiazepines causing low blood sugar and could be critically low, as in his case, to then cause death. I don't know that to be a fact, but it's in the differential.
So benzodiazepine poisoning may cause hypoglycemia. Is that correct?
Yes, there was an article that I cited related to that matter.
Okay. I'd like to go to paragraph 6 on page 4. You state that, quote, the focus on hypoglycemia as the sentinel, or most important, abnormality is surprising. What do you mean by that?
I get further into it in the discussion, but basically, when Mr. Cochran presented, not only was he not alert, not responding to commands, etc., when they tried to figure out what was wrong with him, there were multiple laboratory abnormalities. So they drew his blood, analyzed it, and there were a whole bunch of laboratory abnormalities, including the hypoglycemia, but also elevated white blood cell count. And then that had a part of it when they look at what's composing that white blood cell count called neutrophils. Those are like the soldiers that fight infection. Those were high in number.
Let me stop you right there and ask a quick question. Elevated white blood cell count is more or less showing that there's some kind of infection in the body or some kind of toxins, because white blood cells fight infection. Is that correct?
Especially this component of white blood cells that's now increased the number. They're like the first responders, the neutrophils. And it wasn't just the neutrophils were high, but there's another enzyme called lactate that they tested that was also high that can be seen in sepsis. So it's sort of like painting the picture that, again, that differential, like what could be wrong with him. You then really worry maybe there's an undetected, untreated infection that's causing him to be in this state.
Okay, so, and if this infection was present, which the white blood cells elevated count would indicate, was there any explanation for what this infection is, how it may have occurred, anything about the infection itself?
No. So the clinicians in the ER did say suspected infection, but they did not say what the suspected source was. They just gave him IV antibiotics. And I don't remember which antibiotic, my apologies. But nonetheless, they are also concerned that he was sick from an infection. So it's better to just give him antibiotics and we'll try to stabilize him and then possibly figure it out. That was never figured out from a source, but they did give him intravenous antibiotics. So it got into his body right away.
Okay, now, some mysterious infection in Michael Cochran's body, could that be a possible cause of Michael Cochran's death, either alone or in combination with other things?
Definitely. So if a infection becomes overwhelming and into the blood and really taking over the body, it can be serious enough to cause death.
You talk about there being no suspicion for insulin overdose or self-administration as the cause of Michael Cochran's seizures and coma. I want to make a point here. You listened to some of the testimony. Did you hear any of the testimony that said Michael Cochran did routinely inject himself with insulin? Did you hear any of that?
I think there was some suggestion, I don't remember who said it.
Okay.
It wasn't in the records that I reviewed and made this report based on.
Okay. So given that testimony, an overdose by self-administration is a possibility, right?
After that testimony was given, it's in the differential diagnosis.
Okay. Mhm. Moving on down the page, would you discuss the broad list that you go through of potential causes of hypoglycemia other than an insulin injection?
Sure, this is a very long list. So I think I've used the word differential diagnosis a few times, and it's what we're taught in medical school and then into practice. You consider all the possibilities, some may be more likely than others, but you do testing to sort of tease that apart. Does that make sense? I sort of work broad and then narrow down. And so when you think about hypoglycemia in a living individual or even post-mortem, you have to think what's contributing to this. And so this is a very long list. Do you want me to go through it item by item?
No, just
Okay, we'll read the broad diagnoses and then go from there. So medication induced. That should probably be, whether it be prescribed or not. Alcohol falls into there, some antibiotics.
okay. Let me stop you here. Now, you're listing other possible causes of Michael Cochran's hypoglycemia. Is that what you're doing?
I'm listing what's called the differential diagnosis, whether it's applicable to him or I think this is organized medical way of approaching this laboratory abnormality, and it applies to him. Was this a possibility in him? It's how you have to think, and then if you go so myopic and pinpoint, you might miss something important. So it's always broad to narrow.
Okay. So these are possible causes, not necessarily in Mr. Cochran.
This
but
is medical,
possible.
right?
Okay.
All sorts of causes. So
Okay.
medication related, which alcohol or other unexplained medications may be there. Endocrine, so endocrine is like what Dr. Krieger practices. That's working of glands and hormones in the body. There can be various abnormalities. Pancreatic tumors, that's why I was saying that sometimes we really look at the pancreas to try to see if there's a identifiable tumor. Sometimes they're so small that you really need like an MRI or like a radiology to pinpoint them, but they can be so subtle but still cause medical problems. And then there's other sort of broader issues such as liver disease, in certain cases malnutrition, starvation, critical illness, so like sepsis, which is that overwhelming infection in the body. You can have certain surgeries, like your immune system can attack insulin in and of itself, even though you have a working pancreas, genetic disorders, sometimes eating disorders like over-exercising, not eating enough, that can
Okay.
really throw your body.
Let me interrupt you there for just a moment, okay?
Yes.
You say that other causes include liver disease. Were you aware in the medical records that at some point it was revealed that Michael Cochran, prior to death, had some problems with his liver enzymes?
I'm aware that they're elevated. Usually when I talk about liver disease being a cause of hypoglycemia, it's not just any liver disease, it's severe liver disease.
Okay, but that could be an indicator of liver disease causing hypoglycemia, possibly.
Quite possibly, I'm not clear on the extent of his liver disease.
Okay. You list severe malnutrition or starvation. Were you aware that at certain times, Michael Cochran didn't feed himself adequately, trying to cut his weight for bodybuilding?
I'll take that at face value. I don't know his personal history.
Okay. You say critical illness, sepsis. Sepsis is infection, right?
Correct.
You say immune hypoglycemia. What is that?
It's a rare cause. It's anti-insulin antibodies, so anything autoimmune means your body's reacting to itself.
Okay.
And in this case, it would be a very rare circumstance that your body's attacking its own insulin and then getting rid of it so that your body thinks you don't have it.
And again, these are possible causes
Right.
of hypoglycemia.
Right.
Okay. On down, you talk about non-pancreatic tumors. We've talked about pancreatic tumors already, right?
Correct.
And these are other tumors in the body.
Yes, and I'm no expert in this field, but my understanding is so different tumors can do whatever they want. And there's something called paraneoplastic syndrome. So these tumors that are already abnormal, they're doing their own thing, can start making chemicals that in the body that act like insulin or even make insulin potentially, but your body's getting those signals even though it's not from a normal pancreas, if that makes sense.
Okay. Now, just to fill in a little bit of information, insulin promotes blood glucose or blood sugar, right? Most often, especially in diabetics.
Yes, you need insulin.
You list skipping meals. Is that a real possibility in a bodybuilder who's trying to cut weight?
I'm not really clear on that. I mean, skipping meals potentially, I think it could be. It probably depends on how severe it is. And it's not something I'm an expert in quantifying. I think it can be a slippery slope to get into a malnourished state
Okay.
that could affect electrolytes or, glucose levels.
You say increased exercise without sufficient nutrition. If Michael Cochran was exercising furiously and he wasn't feeding himself properly or sufficient, that could be a cause of his hypoglycemia. Would that be a correct inference?
I think it's in the list of possibilities.
Okay. Let's go down to paragraph 7. May I approach the clerk, Your Honor?
Yes.
Your Honor, I've collected what was previously marked Defendant's Exhibit Number 10. I'd like to show that to the witness.
All right.
It's my chart.
Dr. Banerjee, this is an exhibit that was previously introduced. You created this table that's reflected in Defendant's Exhibit Number 10. Is that correct?
Yes.
Okay. And you also have that in your report, page 6. I'm going to put both of them on the viewer if I can, or
Okay.
just your chart on page 6. Okay? This is your unaltered table. This is the one that the jury has seen previously,
I see. Okay.
except for my handwritten notations as to a conversion of military time to regular time and my circling of certain entries. They're pretty much the same thing. Would that
Yes.
be
Yes.
correct? Okay.
I think they're identical. You just highlighted some stuff.
Okay.
Yeah. And again, with time conversion.
All right.
But the data is not altered.
Okay. Thank you for that explanation. I think I'm going to use your chart, which is unaltered. Okay?
Sounds good.
I'm handing this back to the clerk.
Just like that. Thank you.
Now, Dr. Banerjee, at paragraph 7 of your report, which hopefully you're looking at, you discuss Mr. Cochran's hypoglycemia when he reached the hospital and a timeline of his sugar levels at pages 5 and 6 of your report. And we have page 6 shown.
Yes.
Okay. Now, you created this chart, did you not?
I did.
And it was based on information that you got from the medical records, is that correct?
Correct. So the date and time plus the glucose.
I'm going to get into that.
Okay, sorry.
I'm going to ask you questions about that.
Okay.
I want you to look at the headings at the top of the chart. And I'm talking specifically about right here. Okay?
Okay.
The first asterisk notation at the top is that the alleged event is approximately 12 p.m. on February 6th of 2019. I want to clarify that. Because there's no information reported as to an exact time that Mr. Cochran was allegedly injected with exogenous Lispro insulin, you chose 12 noon on February 6th, 2019, correct?
Yes, based on my review of the investigative information and the medical records, it appeared that that was basically, again, it's approximate. So
Okay.
I'm not saying it's noon, but it's around then that they were saying the event or his
So
problem started.
It's kind of a guess from you, from all these records, because we don't have any exact time, correct?
Correct. There's no exact time, but if I made that assumption, and that's why I asterisked it, that to make a meaningful calculation, I just chose, when they say noon, I chose the number evenly, 12:00, as a time to calculate, as a starting time point.
And that information is essentially gathered from when it's alleged Michael Cochran passed out, and when he got to the hospital and a series of events after that. Is that correct?
Correct.
Okay. The second heading, right here, and you can't see it very well, but it says, hypoglycemia is sugar less than 70 milligrams per deciliter in a person without diabetes. Correct?
Correct. That was the medical definition of hypoglycemia, as I understand it.
Okay. And you remember Dr. Krieger's testimony. She kind of went back and forth. She estimated, but she said at your first timeline on February 6th of 2019 and you've got 2020, which is 8:20 p.m., right?
Correct, on the 6th.
She said, in reference to these questions, that a reading of 21 blood glucose was certainly hypoglycemia or indicated hypoglycemia, right?
I don't recall exactly, but I would agree with that statement.
Okay. But you chose 70 milligrams, and you say that's based on your research and the literature you reviewed. Is that correct?
Sure. So hypoglycemia is a range, or a critical level, if you will, a critical blood sugar. And my understanding and research is that anything below 70 is abnormal, and the lower you get, the more abnormal it is.
The first column is date and time, right?
Yes.
The second column is the reported blood glucose levels in Michael Cochran's body, or allegedly, right?
Yes.
Third column is the hours since the alleged event, and you're picking 12 noon as the alleged event when you believe he may or may not have been introduced with exogenous insulin.
So, right. So let me just clarify. The blood glucose wasn't an allegation. These are laboratory values I've extracted from the medical record. So they're the exact numbers. And again, I had to define a starting point as an assumption, and then those hours are how long after we're looking at those, at that time stamp, if you will, the resultant blood glucose.
Dr. Halsey today testified that he thought the activity of Lispro insulin, or how long it's working in the body, was 4 to 6 hours. Did your research in the literature indicate the same thing?
Yes, so my main source was the manufacturer's insert that has all the sort of description, dosing, and what's called pharmacodynamics, how it works in the body. So it goes through what the activity of this is, because I'm not diabetic.
Okay.
So I had to educate myself.
And I just want to clarify that statement.
Right.
You're talking about if Lilly Pharmaceutical is the manufacturer of this type of insulin.
Yep.
They put a information sheet or sheets in with the Humalog insulin, and they have all of this data in that information, correct?
Correct. I'm familiar with insulin, but I had to refresh my mind with the details of this short-acting insulin. And so what Dr. Halsey said was supported with that literature. It's 4 to 6 hours of, the longest it'll act in the body is 4 to 6 hours.
Okay, and another point of information I have to make clear to the jury. Is it your estimation that once Humalog Lispro insulin is introduced into the body, although it's fast-acting, it still takes time to work, approximately 15 minutes. Is that correct?
Correct. So this is deemed a fast-acting insulin that starts to work about 10 to 15 minutes after injection.
Okay. The first reading has a blood glucose level of 21. Where did that information come from, if you recall?
Yep, it's within the first pages of his medical records when he presented.
Okay. Now, the significance of that is the hours after insulin was allegedly introduced to Mr. Cochran's body. This is 8 hours and 20 minutes afterwards, right?
Yes, approximately.
Can Humalog Lispro insulin possibly be working in the body 8 hours and 20 minutes later?
I can only,
From your research
Right.
and your literature.
exactly, the way I was, that it's been described and I read about, the maximum window of action is up to 6 hours. So we're beyond that time in this chart.
And you have listed in the last column, was Lispro active in his body? You state no at that first entry, correct?
Correct.
Okay. I'm not going to go through all of these listings because the jury's seen it before.
Okay.
Would you describe for me the important blood glucose readings which you have marked in bold?
Sure, it's just for ease of reading and pointing out the events which were hypoglycemia as defined by blood sugar less than 70. There were a total of 4 events during his hospitalization, the first occurring at presentation, and then subsequently on February 7th. There were 3 events throughout the day, or throughout the morning, from a little after midnight all the way through 10:30 in the morning. There were 3 other episodes of hypoglycemia.
Okay. I'm pointing to the first one, correct?
Correct. That's his presentation. Yes.
I'm pointing to the next one, which is right here.
Yes, the second bolded number.
Okay. The third one is right here.
Correct.
And the last bold one is right here.
Yes, the bold doesn't necessarily come through as clearly on the
Yeah,
projection.
that's why I'm trying to point them out.
Got it. Okay.
Now, according to your chart, your research, all the information that you've gathered, if Michael Cochran was allegedly injected with Lispro Humalog insulin, and its activity is 4 to 6 hours, can you affirmatively state that these listings definitively show Michael Cochran could not have been injected with Humalog Lispro insulin to cause these blood glucose readings?
Correct. That this far out, starting 8+ hours out, and based on the nature of Lispro, these are not resulting from that administration.
There was testimony that the volume or amount of Humalog Lispro insulin introduced in the body changed the duration of activity. Is that what you discovered?
Well, I think that's a complicated question. You can't really inject anybody safely with a volume to test it. What Lilly has said, they don't specify dosages, okay? They just say that upon administration to the body, this is the peak time, it starts working at 10 to 15 minutes, it peaks at 1 hour, and then when it fades off, it still has activity up to 6 hours. That's all I can use as a reference.
Okay. Now, if Michael Cochran were injected with another dose at a later time from 12 noon on February 6th,
Okay.
that would actually confirm your listings. In other words, it would put the timeline farther out, and the blood glucose levels could not be affected by a second injection later on. It would, because your first reading is 8 hours and 20 minutes after injection. If someone injects later, it pushes everything back, right?
Correct. This chart is based solely on the assumptions of a single administration around noon. Okay, I was not aware or did not calculate anything based on any other times.
And I think you may have answered this, but I'm going to ask again. Does the volume of insulin introduced affect the duration of the activity in the body? Is its duration still 4 to 6 hours, if you don't?
I don't know.
Okay.
Can I just clarify that answer?
Sure.
Yeah,
go
I
ahead.
mean, I'm basing my information completely based on the manufacturers and published literature. Everywhere that I've read about Lispro, Lispro insulin, that's the time range that's given. It's never differed. It's really reliable. We have a lot of diabetic patients that use it, and it's given basically around meal times too. When you eat, you've got to have a response that diabetics don't have, and so it's well timed out to help them respond to the carb load, the glucose load from meals. So everywhere I've read, it's 10 to 15 minutes after injection, peaks at 1 hour, lasts anywhere from 4 to 6 hours. And I was not provided anything in the literature or the insert to say otherwise.
So the literature and your research, etc., doesn't address the volume question and the duration of activity. Is that right? There's no literature or information about that, as far as you know.
I mean, volume is dependent on the dose you need, the units, which is calculated based on a carbohydrate load. And this is going beyond my expertise because I'm not an endocrinologist.
Okay.
But
okay.
I don't know anything further about Lispro than what I stated.
Fair enough. In a kind of summary and conclusion, all of this discussion that you presented here today in your report, does it indicate, as Dr. Kubitschek stated, that the manner and cause of death are undetermined, and his conclusions and findings say that? He doesn't specifically say any actual manner and cause of death. He says they're undetermined. Do you agree with that finding?
Sure.
Based on all of this testimony in your report?
Yes, my report has detailed my thoughts, and as I've spoken to you today, various factors, regardless of what we think might or might not have happened, the body was decomposed, and both examinations, postmortem examinations, did not help narrow all the possibilities. And so given that, a cause of death is undetermined in my opinion, as well as the manner of death. So causes, why did he die? I cannot tell. And once I can't tell that, although there are various reports of circumstances around his death, I cannot be sure to pigeonhole it further, and so it needs to stay undetermined. So that's how I would certify this death.
Would you agree that any other finding, including Dr. Uribe's conclusion of homicide due to exogenous insulin administration, is unsupported and unsubstantiated by all of your research and testimony?
Yes.
Are your opinions in your report and what you've testified to here today to a reasonable degree of medical probability?
Yes.
And your conclusions, testimony, report, they are in your work as a medico-legal expert and consistent with the standards of your profession?
Yes.
And I believe I've already moved for the admission of Dr. Banerjee's report. If not, I'll do so now.
I think you already have. That's right, Madam Clerk.
Which exhibit is that?
It's 12.
Yeah. 12. It's been entered.
I have the official copy.
Thank you.
Cross-examination?
Okay.
Doctor, you'd agree with me that to make an accurate report and render appropriate opinions, you'd need an accurate history. Isn't that true?
Sure.
Okay. How did you get into this case?
I don't actually remember. I think someone contacted me. I can't tell you. I don't remember who it was.
Okay.
Yeah.
And when they did contact you, what information were you provided? Just the medical reports that you list there?
There's always, I can just be general because I
Go
can't
ahead.
state accurately. So usually when an inquiry comes in for my help, there's some email exchange back and forth. And once I'm officially retained, there's basically saying that I'm going to work on the case that allows me access to the privileged information, such as medical records and investigation. Like no layperson can just ask for that. And so that's where that list of resources that I reviewed was provided to me.
Okay. The actual facts of the case, though, were other than medical records. Where did that come from?
I mean, there's scene photographs. There was potentially some history given to me. I don't recall.
Okay. You don't remember reading any police reports?
I was not given police reports.
You don't remember reviewing any witness statements?
No, I was not given those.
So from what you said about emails, I gather that most of that kind of stuff came from the defense attorneys. Is that
Potentially. My understanding is that a police report was never turned over as discovery. I definitely don't have it in my list.
okay? You've listed and discussed with us your professional background,
Yes.
your work employee. You were the Rhode Island deputy or assistant medical examiner till 21,
Yes.
August 21. Why'd you leave there?
You want to know? My mom had a massive stroke.
Oh, okay.
So please,
I'm
I'd
sorry.
rather not get upset. Yeah.
No, don't do that. And you started your Anchor, I believe is the name of your company?
Yes.
In 16?
Yes.
But you're still a contract medical examiner for 2 jurisdictions, and then sometimes Vegas as well. Is
Yep.
that right? So Maine, New Hampshire.
It's very sporadic. So like, so we are less than 500 medical examiners, board certified in the country. So there's unfortunately many more needs than active bodies. So sometimes we're shared, you help out when you need, when they need, they'll call. But that's variable. I'm also looking to try to get closer to home. My family needs really require that.
Sure.
And that 3-year interval that you're speaking of is when I took care of my disabled mother at home. So I had a 6-year-old, and so the family needs really pulled me away from being on call 24/7, usually once every 2 to 3 weeks a month. So it gets very busy very quickly, including having to give my 3-month-old to my husband to go to a homicide scene. So you can imagine that that's not necessarily conducive to having, also during COVID. Yeah, so, it sort of became too much, and so I decided to step away for personal reasons.
You've indicated you don't know the number of autopsies, and you've done them for years. So
Yes,
that's
yes.
fair. But can you maybe, let's take 2024. Do
Okay.
you know the number you did that year?
I don't, because I was practicing in various areas, but I also do private autopsies. We didn't really get into my full structure of my business as it stands now. So I do this kind of work, which is called expert witness work. I do advise, I interpret autopsies. I do that for lawyers and families. Sometimes they just want to know why their loved one died and they pay for my expertise. Secondly, I also run a private autopsy business. There's not enough, again, forensic pathologist, just because you die doesn't mean you get an autopsy. And so autopsies, I would say medical autopsies, the ones that are not done by a medical examiner office or coroner, whatever the structure may be, because those offices are very heavily inundated with cases that need the legal oversight. I'm hired by families. I've been getting queries every week for private autopsy, so I do those really frequently. And then I also teach. So it's my time is spent, and it's not like I can predict who's going to call me, who's going to, and I don't recall how many I've done, but I do private autopsies at least 2 to 4 a month.
2 to 4 a month. And then, well, that's why I'm trying to get a handle on how many autopsies you did in 24.
I can give you an accurate answer.
Like 300 or less than that?
Probably less than that.
Pardon?
Less than that, probably.
Le-
Yeah.
200?
I don't know. Possibly, because between locums and everything else, yeah.
Okay. You ever heard of an outfit called the National Association of Medical Examiners?
Yes, name.
Okay. And are you a member?
Yes.
Do you know what their accreditation standards require in terms of, to be, lack of a better word, current or accredited?
I don't.
Okay. You've written a bunch of stuff, a bunch of papers.
Yes.
None of them had anything to do with insulin, did they? Unless
No.
you've written some since 23.
No, I have not.
So you've done no research on insulin as a potential murder weapon or cause of death or anything like that?
I mean, I've performed insulin levels at an autopsy level, but from a research standpoint or publishing on it, I have not done that.
Okay. And you've been on TV a lot, and you've done a lot of presentations
Yes.
to national and international organizations. None of those concern insulin either, do you?
No, they do not.
Have you ever been retained in a high-profile case for an insulin investigation?
No,
This is your first one.
correct. As far as I'm aware, they're also exceedingly rare cases, but yes,
Yeah, they are very rare.
yes.
Based upon what you know, wouldn't it be fair to say insulin is almost the perfect weapon if you wanted to kill somebody? It's
I've
pretty
never
close,
tried,
isn't it?
and I've never thought of it as a murder weapon. I know it can be administered in fatal levels, and that's in the differential that we went through of hypoglycemia. I never said it wasn't in the differential.
But that's what I'm trying to get at with you, and you can help us out here.
Sure.
If you wanted to kill somebody, and
I
you
personally
wanted to,
never wanted to kill anybody.
That's kind of the generic.
Okay, my
not,
life's
not,
work is figuring out what happened.
Not the good guy. But if you wanted to,
Okay.
it's very, very difficult to detect for a lot of reasons. For instance, you had mentioned a number of tests that could have been done at Raleigh General Hospital to determine insulin level, and they didn't. And once they start treatment, it's too late, isn't it?
Yes.
So in fairness to the emergency room people, somebody comes in with a blood glucose of 21, the natural reaction would be to raise that up by giving them sugar, wouldn't it?
Yes.
Okay. But once that happens, no testing is going to help out.
Sure.
And that's what makes insulin such an insidious drug to use. If not you,
That
if
characterization, insulin's used for many, many, many purposes, and the characterization is insidious, I object to.
Overruled.
you may answer. Go ahead, doctor.
I'm sorry, can you just restate?
Sure.
There was a little bit of back and forth there.
Sure. If you wanted to kill somebody,
Which I personally do not.
No, which
For
not
the
you.
record, do
I
not.
keep saying you, but please exclude that
Okay.
as directed to you. It's kind of the
Generic, okay.
Yeah. It would be a great weapon to use and not get caught with it?
I think you could use it. I'm not qualifying it as a weapon of, yeah.
All right. If you wanted to kill somebody with insulin, we're not going to use it as a weapon. That would be a very effective way to do it because it's so hard to determine that that's the cause, isn't it?
So from a detection standpoint, if I'm judging it, okay, I'm not talking about the administration and all that. Yes, it's quite difficult. It's a large molecule. It can degrade. You have to suspect it. So it can be challenging to detect. Absolutely.
As understatements go, challenging would be a good way to put it.
Okay.
It's very tough to do.
Correct.
Now, are you familiar with the Clarksburg VA cases?
I don't know.
Okay.
This is my one and only foray into West
Got it.
Virginia.
Oh, well, yeah.
And
I
I'm
understand.
not particularly a nature person, so I don't think I'm like out here otherwise.
You're a city girl.
Yes.
Okay, fair enough. If I could have defendants 12, please.
The chart's right there.
But that's 10.
Oh, 12 is my report.
It is.
I think she may have.
Yeah, I have the
an
formal
exhibit
copy if you
right
need
over
it.
there.
Okay.
Yeah.
Let me borrow that from you, please, Doc. Doctor, let's just go through some of the opinion and supporting facts. And that's what we were talking about earlier.
Sure.
A brief history is that Michael Cochran was 38 years old with possible history of seizure.
Yes.
That's all it is possible. You didn't have anything affirmative in the medical records that said this guy has seizures.
He had a prior episode.
But did they say he had a seizure disorder, or did they just say he has seizures, or we don't know, suspected?
Right. It was one episode, and I don't know that it was worked up further. So I noted the history of, they said possible seizure disorder, I think resulting from that episode that he had. So that's how I stated it.
Is a possible seizure the same thing as a diagnosis of
No,
seizures?
no.
Okay. And the same thing with the possible brain mass. That's not the same thing as here's a brain mass. Is it?
Correct. Yes.
Okay.
I think what they were lending it, and this is directly extracted from the medical records that I reviewed, that they were trying to see if he had a brain mass as a cause of that seizure, adult onset seizure.
And nobody ever found out.
Not that I'm aware of.
Complained of dizziness and basically fainting. Who did he complain to?
I don't recall.
Okay. He later fell to the floor and was unarousable by his wife. Where did that information come from?
Again, this is within all the materials given to me. I couldn't cite a page number or anything like that.
Okay. She, being the defendant, drove him to the ED. That's the emergency department at Raleigh General?
Correct.
Okay. And he had vomited. You list some other things. You don't put in there that his blood glucose was 21 at this point in your report.
It's 2 paragraphs down. If you see it, it's
Right.
not far because it's still within the background.
It is.
Okay, so I don't really get into the labs until later. So it's all with its partners, all the laboratory results I talk about.
Okay. Investigation showed he was taking some unspecified benzodiazepine. Who did the investigation?
I don't know. There was some report of that.
And it was in the form of a positive urine screen, right?
Well, that's there too.
Okay.
Yes,
But
definitely.
the investigation that showed he was taking some unspecified benzodiazepine, there really wasn't any investigation that you know of, was there?
I can't cite a specific. I don't have the police report either. It was never provided.
Same thing with the anabolic steroids. That's just something somebody reported to somebody else.
Well, yes, and any potential history that is reported by whoever is still important, and that's why I note it. You can't just, you take it at face value.
Okay. You note his longstanding use of pseudoephedrine. Was that Sudafed? Is that
That's a brand name. In medical school, we're always taught to do the generic, and pseudoephedrine is how it's documented in that West Virginia state report as well.
okay? But I mean, if that's what he thought he was taking, Sudafed, that would just be a name brand of the stuff you're
So
talking
he
about?
was prescribed it. I don't know, or it was tracked. So I don't know if that's tracked by a pharmacy. I don't know exactly how the states run, but it had months and months of use documented.
Okay. Back before you started working with dead people, you were doing other doctor stuff, right?
Correct. So I always tell people that I did a year of training to know what it's like to treat living people.
Okay. And had you did a rotation in the ER or ED?
So let me backtrack. So
Go ahead.
my only experience in the ER or ED, we sort of use that interchangeably, is through medical school. My preliminary year that you're referring to, so that means similar to Dr. Halsey, the first year of internal medicine training is what I did at UPenn. So I graduated medical school and did that. I did not have any other emergency room training as a part of that internship. Okay, we would go and get patients. They would get worked up in the ER and then admitted to internal medicine, where I could be their intern, their first doctor, their junior doctor. But I never represent myself to be an ER expert or ER physician.
If one of those patients had presented to you from the ER with a blood glucose of 21, that would have gotten your attention, wouldn't it?
I sure hope so,
Yeah. How come?
because it's low.
Very low.
Correct, and I'm hoping the ER wouldn't send someone to me up to the floor. I hope they would take care of that. That's, to me, what an emergency room should do.
In your history of this case, were you told that at one point the defendant made the claim that this Michael Cochran hit his head so hard that he chipped a stone countertop?
I don't know that. I just know that when I read through the medical records, there was a documentation of a fall with possible head trauma. He had a CAT scan done, and there was no internal head trauma. As far as I know, there was nothing like a bump or bruise notated in the medical records. That's really what I'm relying on to make my assessment, because obviously histories can vary, as we've discussed, and so I rely more on the medical history and the medical notations made.
Had he hit his head hard enough to cause damage to a stone countertop, you'd expect to find something, wouldn't you?
I'm sorry, find something where?
Damage through a CT scan, visible bruising, visible cuts, that kind of
Right,
stuff?
so I think the method of detection depends on the answer. So whether it's a physical exam, like a bump or a bruise or laceration, yes. Hard falls, as surprising as it is, don't always yield internal injury. So even at autopsy, we see that people who don't catch their falls, they might have a laceration, but they may not have anything internally, and that's why the CAT scan is done. You can have a bump or bruise on the outside. You really need to make sure what's going on the inside. And per my recollection, his CT scan was completely normal.
And from all accounts of both medical and non-medical people, there was no external evidence of trauma.
Not that I saw noted.
Okay. There is a text from the defendant saying that Michael's been asleep since before 9:34 in the morning. There's no evidence after that he ever regained consciousness. Were you aware of that?
No.
Were you aware that when he allegedly hit his head so hard that he chipped this or broke this countertop, that instead of calling 911, she called 2 construction guys who carried him from the kitchen floor to the couch? Were you aware of that?
No.
Were you aware that she left him lay on the couch until he urinated himself sometime in the afternoon, about 3 or 4 o'clock?
No.
Were you aware that even after that, she didn't take any steps to get him medical care until she showed up at Raleigh General Hospital many hours later?
I don't have a detail of what happened prior. I just know what happened starting at the hospital presentation.
Okay. If this is a mischaracterization, tell me. But it sounds like you're pretty dismissive of the opinions of Drs. Krieger and Uribe.
I mean, Dr. Krieger's really a clinician. And I think as Dr. Dragovich said, she's not really an expert in classifying cause or manner of death. So I am not here to refute. I don't know what honestly, I don't remember a lot of her testimony because it was outside the area of my expertise. I think Dr. Uribe has potentially overstepped. I have a different professional opinion, which I also answered with Mr. Selden, that I think it's the cause and manner of death should both be undetermined based on the condition of the body and what can and cannot be collected from the body or what was, excuse me.
And that's strictly based on the 2 autopsies?
No, and the medical records as well.
Well, you had the benefit of the MRI report from CAMC from February 8th of 2019, didn't you?
It's probably in there, yes. I'm assuming that's after his initial presentation. So assuming it's there, I don't have it memorized.
No. I understand that. But it showed that massive brain swelling, basically.
Yeah, oh yes, there was cerebral edema.
Yeah. But you're not willing to say that you think that caused his death?
So I think if we get into it, cerebral edema is significant, but there's many routes that lead to cerebral edema. Drug overdose is one. Hypoglycemia could be one. But I can't just look at medical records to make a cause of death. That's what the autopsy is there for, okay? So we don't practice in a black box. We always consider the circumstances. We consider whatever records we have made available. But the autopsy is the gold standard, okay? That's where I'm looking at the condition of the body, the organs, and the main data that I take to synthesize my cause and manner of death, along with ancillary studies such as toxicology. So I am here as a forensic pathologist to opine on what I think his cause and manner of death is. And I really can't tell you what that is. His body's too decomposed, and in our field, it is acceptable to use undetermined as a cause of death and undetermined as a manner of death.
It is. But it's also the option of the forensic pathologist to state a determination of what they believe the cause and manner of death was.
They're professional opinions.
They are. The defense has kind of tossed this out here that there were these sinister-sounding purchases from Mexico. Where's stage 2? Oh, very funny, Miss Smarty Pants. It's not here. It's the FBI report. Or is that? No, I'm sorry. That's 17, isn't it? Never mind. 70. Dr. Haney, what's been marked for identification, it actually entered into evidence as state 17. Take a quick look at that, please.
Just to advise, I've not seen this previously.
I understand.
Oh, okay. It's quite detailed. Yes. What would you like me to
Well,
look
just
at?
the conclusions.
Oh, sorry.
The testing.
Where is this? Results or the interpretation? There's quite, which one?
Yeah, could I have that back?
Oh, sorry, yeah, there's a lot going on.
Take a look at Item 3.
Can I just read it?
Yes, please.
Okay.
Take time.
Item 3 was a bottle marked in part as, quote, enclomiphene citrate, containing a clear, colorless liquid. It goes on to state it was containing glycerol and letrozole, and clomiphene was not identified.
So the mysterious and sinister sounding Mexican purchased drugs were not what they were purported to be.
It was a different one.
Yeah, it was a different one. Not the same thing at all, is
Your
it?
Honor, I'm objecting to this line of questioning. We don't know what these substances were. They weren't actually clarified. They weren't stated. They're just unknown substances.
Overall,
It's the FBI report. I think it's a known substance. Wouldn't you agree with that, Doctor?
I'm just reading what they reported.
Right. But you have no reason to question the FBI lab results, do you?
I'm taking it at face value.
Okay.
Just to clarify, Your Honor, I'm not objecting to the FBI report. I'm objecting to the so-called Mexican substances, which were never documented. We don't know what they were.
Well, the state would agree with that. They were never documented.
I understand the objection is overruled. I'll preserve your exception.
This is a text from the defendant. And I call your attention to this part. Mike was so mad this AM about not being able to go today, he had to take 2 of my blood pressure pills. Did you see any evidence from the medical records of a blood pressure pill in the Michael Cochran system?
I'm sorry, let's clarify. In his system, like a postmortem
Do you have
toxicology?
any medical records that say he had taken 2 blood pressure pills?
I don't have any data to support
No.
that. Okay.
You don't.
And no toxicology.
Right.
Yeah.
And again, the defendant affirms that he'd taken 2 of her blood pressure pills. And you don't know, medically, there's no evidence of that one way or the other. Right?
Okay, I'm not sure how this leads back to my cause and manner of death.
We're
but-
gonna get
Okay.
there. Bear with me. We're right on the doorstep.
Okay.
At 102, this picture goes out, and the defendant says that she checked his blood glucose, and it was 145. Can you read that?
No.
Oh, there you
It's-
go.
Okay.
Now you can
Yeah.
read it. That's my fault.
Okay. And it's a lot hazier on my screen as well, but yes. It's just a listing of some vital signs and a blood glucose of 145.
And that's at 105, 106, 102.
I have no idea the timestamps cut off.
Here's another one
Okay.
to a different person.
Okay, yeah. That says a timestamp of 106.
Okay. Bear that time and that number in mind, please.
Okay.
Did you know that?
No, I did not.
At 6:30, the defendant says blood sugar 115.
Okay.
Correct?
Yes, that's what it says in the text message.
We can either use defendant's 10 or we'll just use the same chart from
Oh,
your...
sure, okay.
Okay. You were not told about those 2 blood glucose level measurements until today. Is that right?
Correct.
The very top of your chart, you base your chart on the assumption that an alleged event occurred at approximately 12 o'clock.
Correct.
The alleged event was what?
That's when he fainted and due to possible exogenous insulin administration.
Would the two readings that she claims she got, would that be consistent with a 12 o'clock on a non-diabetic injection?
It could, because I don't know what all is in his system. Obviously, there's some drugs that are not the correct ones, and I have no way of assessing what was in his system. My understanding is he used multiple supplements that are not regulated by the FDA, and I don't know. And so whether they're foreign, domestic, et cetera, I have no idea what any medication's effects would be on him, his blood glucose, his other vitals, et cetera.
Well, those are all unknowns, and those are fair points. But we do have a known. When he got to Raleigh General 2 hours later, his blood glucose was 21, right?
Yes.
And so in theory, it dropped from 115 to 21 in a couple hours.
Okay.
Now, Doctor, you are not expected to be familiar with Raleigh County geography, but I'm going to ask you to assume that this is true.
Okay.
From the defendant's residence on 4H Lake Road to Raleigh General Hospital would be approximately a 30-minute trip. Accept that for the moment, okay? On February 6th of 2019, at 7:30 in the evening, it would be dark, correct?
In this, well, it's February, so right, still winter time, yes, relatively so, yes, I would say. Shorter days.
Now, in your information coming to you was that this defendant drove her husband to the ER.
That's right.
In fact, his best friend drove him to the ER.
Sure.
He was laid out in the back of the SUV, and she was with him. Those are the only three people in the vehicle.
Okay.
It's night. It's 7:30 or so, and by the time they get to Raleigh General Hospital, his blood glucose is 21.
Yes.
Does your chart or does your report in any way negate the possibility that he received one, more than one injection of insulin, or two, when he got it? You don't know.
That chart is solely based on those assumptions as
Assumption.
stated, okay?
Fair
So
enough.
I haven't made other charts based on other scenarios.
Right.
It's all it's that approximation, and anything else would be a chart based on another hypothetical situation.
Based upon your research into Humalog, it would kick in how many minutes? 5 to 25 minutes?
I had 10 to 15, but sure.
10 to 15 minutes?
Okay, yeah.
Okay. So that's when the Humalog would be effective.
So what I read, just to restate clearly, is that you administer it 10 to 15 minutes later, it sort of gets into the system and starts acting. It peaks at 1 hour and can last anywhere from 4 to 6 hours.
And the effect of that would be to bring down the blood glucose level, correct?
That's what insulin does, yes.
Doctor, you, on the last portion of your report, you say, I am relying on information you have provided me at the present time. Thus, my opinions are preliminary, may change if other information is offered for me to review. And you reserve the right to change your...
Absolutely.
Since you were not provided with blood glucose readings in the afternoon or the early evening, you were not provided with the circumstances under which the victim or Mr. Cochran got to the hospital, that's all new information to you today, isn't it?
Yes, it is.
Are you aware that the defendant is a trained pharmacist?
I was told that, but I don't know her qualifications.
Okay. Are you aware that she held herself out to be a specialist in diabetes?
I did not know that.
Wouldn't you agree with me that someone with that kind of background and training would be well acquainted with the impact of insulin?
I don't have any way to judge that. I assume so. If she has those qualifications, even as a medical student, I was aware of insulin, and I'm sure parents who have, or other people who deal with diabetes know how insulin works, but I haven't judged her on her qualifications or discussed it with her.
Right. But just as kind of a generic matter, somebody that's a pharmacist and an insulin specialist would certainly be well acquainted with insulin and how it affects the human body.
Correct. If those first two statements are true, then the conclusion would be that he or she should know how insulin works.
Right. Doctor, you've been presented with a bunch of new information today. Has any of that caused you to change or alter your opinion?
No, it has not.
Thank you, Doctor.
Redirect Mr. Sullivan.
Thank you, Your Honor. Dr. Banerjee, since the prosecutor has brought it up about other cases, what famous cases have you worked on before?
I don't know what's famous per se, but
Well-known, a
Well,
lot
you
of
get-
notoriety, a lot
I
of
mean-
press coverage.
yeah, it's hard for me to distinguish in the sense that some of them I consult on and some of them I cover as an expert in the media. Personally, I feel very proud. I know I worked on Breonna Taylor's case for the civil suit.
I'm sorry.
Oh,
Could you
Breonna
please speak
Taylor.
up a
She
little
was
bit or
she was a
get closer?
shooting victim. So that was an important interpretation. I worked with an attorney on that case.
Mm-hmm.
I don't want to say more about it, but I cover, so my work as an assistant medical examiner was dealing with deaths within the state of Rhode Island. One of my cases was made into a forensic files that I was interviewed for, and it's also an A&E show. So I don't know if that's famous, but it's been on TV. My specific work on those cases, it was solving actually a very decomposed person solving that murder. So that's one way, I guess you can say, famous. I work on a litany of cases, and it was asked how I was contacted. It's whoever decides to contact me. And then I also do commentary or whatnot, and I'm presented with very, I would say, more known information where I'm not the primary autopsy pathologist.
Okay.
And then everything in between, right? When I do legal consulting, I'm given privileged information, right? So I say retained, meaning that I'm allowed to work with the attorneys and get medical records or private information and then give my opinion on the case.
Okay. Now the prosecutor went to great lengths to talk about insulin as a perfect murder weapon, unquote.
Definitely
Is
his
it-
words, not mine. Yes.
I'm going to clarify
Okay.
that. Now, insulin is not a perfect murder weapon because it can be detected when someone's admitted to the hospital, right? There are tests to detect it then, right?
Tests exist, they can be done.
Right. And even after death, post-mortem, there are tests to test for insulin in the tissues, in the fluids, etc., right?
It's possible, yes. The body has to be much more intact, so it'd be soon after death, but it can be done.
Right. If you were told that Michael Cochran's body was not cremated, wouldn't any signs of insulin that you could trace or find out about post-mortem be destroyed by cremation?
The whole body is destroyed with cremation, so that's
Right. And
a very
And-
one-directional process, if you will.
okay. And if someone was trying to hide a murder by insulin, wouldn't it be wise to cremate the body?
I think that's speculation. I have no opinion on the matter. At this point, I mean, cremation turns the body into ash. It's a high temperature process.
And you couldn't test that body for anything if it's turned to ash post-mortem, right?
Correct, correct.
Now, were you aware in the medical records that Michael Cochran had a seizure event in October 31st of 2018 through about the first week or two of November 2018?
I'll believe the dates, but I know it was like the year before. That's where that seizure event happened and where this possible brain mass was suggested.
Right. And that's well documented in the records, isn't it?
That was solely extracted from the records. I just used those facts.
Were you aware that Michael Cochran was subsequently referred to a Dr. Melanie Ward, who prescribed for him anti-seizure medication?
I'm not aware.
If that doctor prescribed anti-seizure medication, that would suggest he had seizures, right?
I know he had that seizure. I don't know about subsequent seizures.
And there was talk about Michael Cochran's blood glucose level being 21 when he arrived at the emergency room in the hospital. If that occurred, if his blood glucose level was 21 when he gets to the emergency room, they treat that, don't they? They try and raise the blood glucose level by administering glucagon or dextrose or D50, right?
So I'm not an emergency room provider, but in him, he got a vial of D50, which is a high concentration dextrose solution, to try to give him a dose of sugar, a high dose of sugar.
And D50 does normally raise the blood glucose levels, right?
Yes, it's supposed to,
Okay.
yes.
Now, perhaps Dr. Dragovich would have better addressed this question, but if someone has a head injury, like is alleged in this matter, fall, hit their head on the counter, pass out, fall to the floor, you don't always have an external sign on the head of any kind of concussion, right? And I'll give you an example. There are many examples of, like, football players who sustain a concussion while playing. There's no external signs of it. And later on, it surfaces that they indeed had a concussion that causes brain problems. You aware of that?
I don't feel comfortable commenting on that. I can talk to you about postmortem diagnosis of what I've seen in brains with and without a concussion history. About the clinical presentation of concussion, I don't diagnose concussion. I do watch a lot of football.
And you're a Buffalo Bills fan, right?
No.
No.
I'm a Ravens fan.
Oh, okay.
That's on the record. And so I'm very sad about the Super Bowl. Nonetheless, sorry.
All right.
I was up late watching, but yes. Where was I? I don't clinically make any assessment of concussions. If it's noted in the history, just like if a seizure is noted in the history, that would be a significant history. But a concussion brain, even at autopsy, can look completely normal. which is always something that surprised me because it can be a significant impact leading, that the person sustained previously. And there can be microscopic signs, again, getting into wider diagnosis and issues. But, nothing is also always present or always absent. So
Okay.
nothing in medicine is 100%.
Your chart, that by the way is still on the viewer,
Oh, it is. Well, partially, yes.
those numbers are strictly from medical records that you reviewed, is that right?
So I want to do one thing. So the date, the glucose were extracted data points, okay? I used a time calculator to then calculate the interval. So it's not like the medical records had that time since 12 o'clock. And then I did an interpretation based on the medically available activity of Lispro to say whether it would have been based on that time calculation, whether it would have been in the body. That's exactly how that chart was formed.
But what I'm getting at is you weren't provided emails, you don't know about statements of other people, blood glucose levels at various times during the day, unless they were documented in the medical records. Would that
Correct.
be
I showed you the sources, and I told you the sources of which I relied on to form my opinion.
A moment, Your Honor.
All right.
Now, Michael Cochran was definitely diagnosed with an enlarged heart, and he had that condition, which is well documented. Isn't that correct?
I think there was suggestion of it in the medical records. It's well documented at autopsy. That's the most important finding.
Okay. Now, wouldn't an enlarged heart on autopsy support the proposition that Michael had high blood pressure?
So it's not necessarily a diagnosis of hypertension, which is what we in lay terms call high blood pressure. I think that is like a genetic disease, which runs in my family as well, and many families, and is a common ailment. However, if you use medicines that relatively raise blood pressure and use them for a long time, they can have the same effect on the heart as having high blood pressure. Does that make sense? It's not high blood pressure in the hypertension diagnosis sense. It's a sequela of using a stimulant like the pseudoephedrine, which is a stimulant, and that acts to tighten the blood vessels, which then would raise your blood pressure. So if you do that long enough, that could cause that enlargement of the heart.
Okay. Now, if someone like Michael Cochran had high blood pressure, but they were attempting to hide it from their doctors.
Wait a minute. This is way out of line.
Sustained.
Okay. You have no concept of the geography in and around Beckley, correct?
No, sir. I walked half a block at lunch. That's about it.
So if the address of Michael and Natalie Cochran were on 4H Lake Road and it's only 7 miles to Raleigh General Hospital, would you accept the prosecutor's proposition that it took 30 minutes to get there? Does that sound reasonable?
I have no way to say
Okay.
one way or the other.
All right. I don't have anything else, Your Honor. Thank you.
All right. Any further questions, Mr. Truman?
The defense brought up about Dr. Dragovich, and the two of you seem to be a little bit apart on this. He indicated that cancerous tumors are tougher, for lack of a better word. You were here. You heard what he said.
Oh, yes.
There was never a finding of a pancreatic tumor was there?
So let me break that down in two parts. One is there in the medical records, there was no documentation, okay? In the autopsy, you could see by the condition of the body that even at the first autopsy that I'm saying, the pancreas does something called autolysis. It eats itself due to the enzymes. And even with which is sort of like dissolving it with acid, if you will, right? It like sort of disintegrates. And so even a tougher tumor, which I don't know that information, he offered that, but now to comment on that, it would still be susceptible to complete degradation by the time the first autopsy was done.
I guess the answer to my question is no. There was never a pancreatic tumor found in Michael Cochran.
So I can't agree to that because.
There was one found?
Please let me explain.
Sure.
Okay, that's what I'm here to do. One is in the medical records there wasn't, okay? I think a decomposed body, you cannot conclude whether one was or was not there. That is a limitation. So, right, it is handicapped. So I cannot accurately say if the organ's not there or so in poor shape to evaluate, I'm limited by that to say whether a tumor had been there.
That's not what I'm asking. The question is, there was no tumor found in his pancreas, was there? Not
By
why.
who? By who?
Kubitschek.
Dr. Kubitschek did not find one.
Okay. Do forensic pathologists rely solely on what they find in the dead body?
No.
They
So
don't.
if I can explain that,
Sure.
yeah, that we don't practice in a black box, okay? But I think, again, the autopsy is a gold standard. That is the collection of data that's collecting as much evidence, and we have a unique perspective, right? No one else is doing the dissection or collecting that data, like where Dr. Krieger is not qualified to comment on cause and manner of death. With that being said, you still take the investigation into, or the circumstances surrounding death into play. But there are so many unknowns here that undetermined cause and manner are appropriate.
Right. Would an enlarged heart in and of itself cause hypoglycemia?
No, but if he has an arrhythmia and then starts getting dysregulated, he could have hypoglycemia.
And that would just happen within minutes, hours?
I couldn't say.
Okay. And would an enlarged heart cause a blood glucose level of 21?
Again, it's not a direct cause. If he becomes dysregulated, if his body's shutting down, that could happen.
And that would take how long?
I don't know. We're all different.
Okay. Doctor, thank you. That's all the questions the state has.
Anything, Mr. Selvin?
Very shortly. Doctor, the pancreas, which is responsible for insulin production in the body, is an internal organ of the body, right?
One of the major organs
Okay.
that I look at every case. Yes, we all have one.
And isn't it true when the body begins to decompose after death
Yes.
that the internal organs, like the pancreas, are the first to decompose?
So
As opposed to the skin,
okay.
the hair, the bones.
So everything starts decomposing. Some at faster faster rates than others. I mean, if we look at everything at the microscopic level, once the person is deceased, not getting oxygen, everything is disintegrating. We're no longer living. We're not getting the nourishment. Okay, but I would say the GI tract, meaning the tube, the stomach, your esophagus, stomach, pancreas, etc., gallbladder, those are very sensitive organs full of enzymes and bacteria that normally live there and are contained, but upon death are released or penetrate through to first decompose these structures, and they're very susceptible to decomposition.
Okay. And after a body has been decomposing after death, and it's 7 months before an autopsy is done, you could not tell whether there were microscopic pancreatic tumors because of the state of decomposition. Isn't that true?
This was a moderate state of decomposition with insect activity, which would limit analysis of all organs, especially the pancreas.
No further questions.
Anything, Mr. Truman?
That's for the fun state, Your Honor. Thank you.
Thank you very much, Doctor. You may step down. You are excused.